from animal studies to human studies, that's something you need. And there's a whole scala of parameters that you can use for measuring kidney function with some advantages and disadvantages. And then the second part is a bit more of research. I would like to point out to you that research doesn't need to be rocket science or very expensive ones. This is research we've done with very limited resources and with some very practical results we can use in everyday lab practice. So kidney function, I think you're familiar with the structure of the kidney and the nephron, which is able to produce the urine and clear the blood from all kinds of analytes. And it's of course important how can we measure the function of this glomerulus and how does it work. For these we have several parameters available. For instance, the glomerular filtration rate is the thing we want to measure. It's important in monitoring nephrotoxic medications in everyday practice in a clinical hospital lab. Also in pregnancy, diabetes mellitus, hypertension. The kidney is one of the first organs which is diseased by diabetes and by hypertension. Also in hemodialysis, multiple myeloma, and other kind of kidney diseases, it's important to have an idea about the function of the kidney. It's important to have an early parameter which gives you time to have a good intervention and to preserve the rest of the kidney function, the remaining function. Just as a reminder, these are the cutoffs we use for glomerular filtration rate. We have 5 stages of kidney disease. Normal is a GFR above 90 milliliter per minute. This is standardization for a body surface area. Usually people mention the 90 milliliters per minute. And then you have several classes of impairment of clinical kidney function. Now, what we are looking for a good marker for the kidney function is that it's an affordable one, because it's important with the upcoming incidence of diabetes mellitus, of hypertension. It's important to have a tool that is cheap, so you can do a mass screening in all kinds of population, so you can cut the diminishing function of the kidney in time. It's also handy to have a parameter that has an in vivo synthesis. It's more handy than when you have to administer something that's foreign from the body. That's much more inconvenient than when you have a parameter that's present in vivo. You also need a constant synthesis. With that I mean that, for instance, inflammation should not interfere or should not influence the marker in a positive or negative way. Are you familiar with positive and negative acute phase proteins? Can you give an example of positive acute phase proteins? For instance, in blood inflammation. Do you have possibilities? For instance, here on the first row, can you mention any protein that rises with inflammation? Sorry? Yes, these are possibilities. Any negative acute phase proteins? This is more difficult, there are not so many. Not the most abundant proteins in blood. For instance, albumin is a negative acute phase protein. So that's also important to have an idea about that, because albumin is one of the most abundant proteins in blood. It's important to remember that when with the raise of CRP you have a diminishment of albumin. Another important criterion is that you need a balance in excretion and production, that it's independent of body mass, of things like that. And of course you want the parameter to be sensitive. You want an early detection of a late one. One of the most parameters mostly used is creatinine. This is the classically clearance when you measure the serum creatinine and urinary creatinine, and you see what the output is of the urine. Of course, for a lab environment and for clinical practice, this is not very practicable. You have to have a collection of urine. You have to measure 2 parameters, so that's not very convenient. It's a correct way of measurement, but it's not very convenient in everyday practice. That's why also other clearance parameters have been developed, like inulin, chromedipia. These are all administered to the body, so that's also a good parameter, the inulin clearance, but it's not very convenient. And of course the creatinine, which is typically present in blood, so that's convenient to use. these are some of the problems which I pointed out with when you use urine, for instance, and creatinine in urine. You need a urine collection. That's very problematic. You've got a large intra-individual CV, and the gold standards like inulin, EDGA, they are expensive, and it's a lot of work. You have to have attendance of doctors present, etc. So that's a lot more expensive and more work. That's why they, in lab environment, they always have been searching for better formulas for calculating the GFR, as they call it, the estimated GFR, based on one measurement of one parameter in serum. Typically, creatinine is used for that because GFR is the best overall index, and it's very convenient in clinical practice in contrast to the gold standard estimation. It's also, when you calculate the estimated GFR, that's also more sensitive for diagnosing kidney disease than the serum creatinine alone. Of course, you could say we measure the creatinine, we have a cutoff, and so we can see whether it's above or below the cutoff what the situation of the kidney is. But that's not always the case, because there's something like the creatinine blind range. That's a very important issue that, that we will go into in this slide. What you see here is the serum creatinine in function of here the inulin clearance. This one you have to look at. What you see with a lower clearance is the function of the glomerulus. Serum creatinine. What you see here is that your creatinine, sorry, what should I say? What you see here is that in this cases of diminished clearance, diminished renal function, like here you have hyperfiltration, normal value, and this is the area of renal failure. In renal failure, it's normal that your serum creatinine rises. That's of course evidently, but what you see here is that even when you have the beginning of renal failure, that your creatinine is still normal. So when you use a single cutoff for creatinine and a single measurement, these are the patients you are going to miss, and this is a very important area because this is the early damage. So this early kidney damage is something you're gonna overlook when you use serum creatinine by itself. So this is one of the disadvantages, but why are people still interested in measuring creatinine, since the parameter itself is not very reliable in all situations, but it's very cheap. It's only a few euro cents that it costs. We've got several methods, so it's readily available at all large platforms in the lab. Well, and it's a very simple, straightforward technique. There are also other methods, enzymatic methods, but they are much more expensive. But they have the best agreement with the reference method, is the isotope diluted mass spectrometry. But I must say that the serum creatinine, these endpoint and rate calibrated, they're also very calibrated and have a good correlation with IBMS. So serum creatinine, it's cheap, but this is a summary of all the problems that you can have with this parameter. There are non-renal influences like sex, age, and ethnicity. In blacks, you have to have other cutoffs and other cutoffs. There's also influence of diet, with large meat consumption. You have an influence of creatinine. Also the use of drugs and muscle mass. Creatinine is a parameter you cannot use in people with amputations or with very broad muscle wasting. Then it's not useful. For instance, the very tiny old lady at the intensive care unit, well, then you have a diminished creatinine and you will miss the beginning renal failure. In contrast, for instance, with a bodybuilder, we will have a higher creatinine value. There are also some analytical problems, but most of them have overcome. There's a better standardization. The interference is something that is still of importance. So as a lab, we have to test for ecteric, glycemic, and hemolytic samples because this interferes with the assay. And the standardization now is an issue that is solved for most new assets for manufacturers. So that's why people still want to use creatinine as in a formula for calculating the estimated GFR. You can estimate the GFR from the prediction equations, and what you have to take into account is one serum parameter you measure, and that's serum creatinine, also cheap and readily available. And you can add some information by using information about gender, age, race, and body size. And these are the formulas, I'll give some examples later on, that are used nowadays for calculating the eGFR. For instance, these are some of the formulas that are available. Now, there are a lot of formulas. What I would like to point out is that when you use a calculator on the internet, be very aware of the method for creatinine that they demand. You have different calibrations of the methods, so preferably use a method that is IDMS calibrated, and you check that the formula uses these creatinine values. For instance, if you can see here, these are the conventional formulas in which you have this factor, and these are the new formulas with new calibrations. These are traceable to IDMS, and then you have a totally different formula. So it's important to check for this when you use automated calculation. And these formulas are the most used, the MDRD and the CKD EP formula. These are the most frequently used in lab, because this is something that you can report as lab. The only parameter you have to measure is serum creatinine. Age is also mostly known in lab, that's not an issue. Sex, well, that's something you know in your laboratory information system. Only race is not available. So usually we report a value and report that if ethnicity is a black person, then you have to add an extra value for measurement or for reporting and calculating the estimated GFR. And this is a practical formula because the MDRD formula and also these CKD-EP formula can only be used in persons older than 18 years of age. And for little children, there's still the use of the Schwartz formula. But then this makes the situation a bit more complicated. Specifically for children, you should use you should not use the newest compensated methods. You have to have a recalculation, so you can, or you use an adopted Schwartz formula, but not a classic Schwartz formula. Well, the Cockcroft and Gold formula, which you can find in the older textbooks, is still valid if you use it as a method of compensated methods. Compensated means the one that is traceable to the IDMS. Okay. This was a parameter creatinine. Because it's cheap and easily measurable, it's still used widely. If you use it as a calculation for eGFR, you can use it for large screening populations. It's cheap and convenient. But of course, I've mentioned the disadvantages, and that's why people and researchers are still looking for new parameters which become available. One of these new ones is cystatin C. Cystatin C is also measurable in serum. One of the disadvantages is that the routine methods are limited available, so you don't have it available on all large platforms, usually in the ELISA format, and some specific manufacturers can offer this parameter. One of the disadvantages is also that it's increased when administering steroids, for instance in transplant patients, and it's also increased in certain tumors. But one of the large advantages is that there's a straightforward correlation with GFR. It's independent of muscle mass, independent of diet, so it's very steady state protein. You don't need to measure it in urine, only in serum. And it's much more sensitive in the blind range of some of the creatinine, so you have a much earlier discovery of the kidney disease. Also, one of the new ones is beta-phase protein. It's used in the same way almost as cystatin C. It's also a very small protein. It does not have the same disadvantages like steroid administration, etc. It has the same sensitivity in creatinine blind range. It's also HN muscle independent, but the disadvantage is that there's no international standard. So you can't compare one method with another. if you have several methods. If you see this in literature, it's always important to have a reaction when there's not an international standard. Every manufacturers try to have their own standards, best efforts, but you can't compare one method with another. So you can't use the cutoffs from one method for another one. That's the advantage of cystatin C or creatinine and all the methods. There's an international standard to which every manufacturer has to compare. And this is the third one, beta-3 microglobulin. It's also a very small protein of 11,000 daltons. It's also age and muscle mass independent. Some of the disadvantages is that it's an acute phase protein, so it rises with inflammation. And if you use it in you always have to check for instance for the C-reactive protein. And it's also increased in patients with several malignancies, typically the lymphoproliferative disorders. So that's something you have to check for if you use this parameter. But here you can see an illustration when you compare these parameters like beta-trace protein, cystatin C with creatinine. You can see here the GFR, of which you have an almost normal kidney function and a diminishing function. Then you can see that with creatinine, this is what we have called the creatinine band range. So you can discover the damage to the kidney, but with the new parameters, you can have a very early discovery of diminishment in the glomerular filtration. And you also see that the differences are much bigger, so that's also more convenient to use in clinical review. Okay, that's what I wanted to talk about creatinine and screening for kidney function. Then there was a part of which is more research related, and some research results we have. We can use urine in a lot of interesting ways. It's a very wonderful and useful sample because it's produced in massive amounts. It's easily available. Patients don't have to be to have a vena puncture to obtain the sample. Usually without pain or difficult techniques, you can have urine available. Pre-sampling is very easy, but there are of course some disadvantages. The disadvantages in urine is what urine do you take? Do you take an early morning sample? Do you take the second Freud? Do you take a midstream sample? Do you have to have a collection, 12 hours, 24 hours? What sample do we need? And that's sometimes a problem in clinical review. Depends on what analyte you want to measure, what disease you want to discover. That makes out what kind of sample to use. For instance, when you have a microbiology sample, then it's best to have the first morning Freudian urine, because then you can use the bladder as a sort of incubator of the bacteria, and you can increase the number of bacteria. Would you like some information about proteins, for instance? Then it's much easier. It's not the best sample to have the first morning Freudian urine. Then you need one further on because that's more related with the true situation of the protein shattered by the kidney. Now, screening for early kidney damage is usually done with albuminuria because this is one parameter that albuminuria is shattered by the kidney in early damage by hypertension and diabetes. That's also the reason that in Belgium, for screening for diabetes, that this parameter is reimbursed. Strangely enough, it's not reimbursed for hypertension patients. It's an independent risk factor for cardiovascular disease. If you see that microalbuminuria is present, then you have a higher risk of cardiovascular diseases. Classically, test strips are used for the screening. Now, you should be aware that the usual test strips which you can measure or interpret with naked eye is that the limit usually is about 20 milligrams per deciliter, while the early damage is about 20 milligrams per liter. So this is 10 times smaller amount of the protein. So you should be able to, if you use albuminuria as a screening mark for kidney damage, you should focus on this kind of cutoff to reach, and not the classic test strip, which you can read as such. Now these are the methods that are available for which are very sensitive for the low levels of albuminuria. You have some specific test strips like Migral tests, but these are very expensive because it's a more immunological method. It's not as cheap as the routinely available test strips. You've got the classic chemistry and the volumetric methods. What I would like to point out is that with certain machines, we are able to use routine test strips in this area of 20 milligrams per liter. And for those interested in third world countries and then problems with Lebanon and Israel, I also have some examples of very cheap screening methods which you would use in this kind of settings in third world countries, for instance. These are the classical test strips, you all know, classically red naked, but with some new techniques and with specific machines we can use with LED lighting and a very sensitive detector. You can use these test strips to have a much better cutoff available. For instance, this is what we obtained with the classical test strips, which are available at the classic pharmacists, which are used in the cabinets of the medical doctors. But when you use this specific machine, the Uresis, we could reach cutoffs of 30 milligrams per liter. That's almost the cutoff we need for detection of the first kidney damage of 20 milligrams per liter. So even these cheap test strips could be used for mass screening on a cheap way for large population studies. It's not the best cutoff, but it's affordable and it's acceptable in this situation. This is the method which you could use in third world countries. It's very easy, it's also very stable, it's temperature independent. The only thing we need is cellulose acetate test paper that's cheap and readily available. There are several methods you could use, but it's almost always the same. You make a standard concentration of urines. We can see here, S1 to S9. These are, for instance, patient samples. You have several concentrations of proteins. You apply the urine just in a spot on every way here on this paper, and you can stain it with several available and cheap stains. For instance, niclosine is used. Also, the silver stain is possible. So you don't combine them. You use either the niclosine or the silver stain. You rinse and let dry, and you have a manual readout of what protein concentration you have. And you can see here, if, for instance, this is 20 milligrams per liter, you can see which patient has kidney damage and which one you should follow up. So this is a cheap and very fast method also. Now, also a very important issue about using, for instance, these stains is that you stain proteins, but several proteins have a different, what should I say, the staining is not as sensitive for every protein in equal ways. And that's what you see here. These are some proteins you can find in urine, like for instance the albumin that we have talked about. You can also have Ben-Jones proteins. Is that something that you know, Ben-Jones proteins? Is that something you're familiar with? No? These are the light chains you can see in lymphoproliferative disease, kappa and lambda light chains. Also, Tan-Holzfeld glycoproteins are present in urine. These are just some proteins that are shedded by the tubulus in the kidney. They have no specific function, but you can easily find them in urine. And of course, sometimes gamma globulins, if you have a large damage of the glomerulus, you also lose your higher proteins like the gamma globulins. And you can see when you use different stains that the sensitivity for coloring these proteins differs from stain to stain. So that makes that one stain is not comparable with other. Luckily, albumin sensitivity is very good, so that's what you want. The Ben-Jones proteins is something you would not like to miss, because that's also very important information. If you have Ben-Jones proteins in urine, then there's a possibility that these can also damage the kidney if they are in too large amounts present in urine. tan-host lipoprotein, that's not that important. So it's not a big deal if you miss it, but you can see that it colors with these stains, so that could cause some false positive results. And also gamma-globulins with silver stain are stained very good, with the nicotine not that good as well. And this also explains differences which you can find in when you use methods with color stains or methods with immunological antibodies. These are very more specific to, for instance, albumin, and that's why you can't compare all these methods with one another. One important understanding I would like to point out is in recent literature there was a lot of debate about the difference between immunoreactive and non-reactive albumin. The thing is that one of the philosophies, I say it's very controversial, there are believers and non-believers, but one of the things that's the theory about the albumin is that what you see here is part of the tubule of the kidney. This is the urine, the ureter space. You have the glomerulus filtered albumin. What happens is that albumin is, by anesthetic ways, is taken up into the tubule. But when there's a damage, of course, as a protein is degraded within the lysosomes. But when there's a damage, then the albumin retrieval pathway is disrupted, and you get a backflow of albumin fragments. And this is a difference between several methods that you can find. In this situation, when you use an immunological-based method, you won't find any albumin. You can't measure it because your epitopes are destroyed. But with the color methods, you still measure this. And this, for example, is what you can see here in different methods. Like, for instance, the radioimmunoassay, which uses immunological antibodies, and you have an underestimation compared to HPLC, in which you detect the protein residues much better. And so in a low range of albumin concentrations, it's possible that you have a high results with HPLC and things you miss with radioimmunoassays. It's controversial, it's not evident if this is of any meaning or not. Can this be reproduced with other measurements? That's not always clear. But this also contributes to the possible differences in the methods. Okay, the second part of the more research-orientated thing is about proteinuria. You want to detect and identify the proteins in urine, because this allows you to identify on which level the damage in the kidney is present. For instance, if you can see that proteins in urine are from glomerular level, then it's possible that you have a selective loss of proteins in which you lose albumin, but not the big ones like the immunoglobulins. But when the glomerulus is very much destroyed, you have non-selective proteinuria, in which you have a loss of also the big proteins like the gamma globulins. With this technique of electrophoresis, you can also see if there's a tubular damage, so you can see no molecular proteins present. Okay. You can see if it's post-renal origin. For instance, when you samples obtained by categorization of the urine tract, then it's possible, of course, that there's a damage of the urethra, and the proteins you find then are not a mirror of the situation of the kidney. So it's important that you know, okay, there's a proteinuria present, but it's not from the kidney, it's from the urethra. And that's in these circumstances we use up-to-date microglobulins. This is a very large protein. Even in large damaging of the glomerulus, it won't be shed in the urine by the glomerulus itself. It's too large, it won't go through. And if you find this in urine, the alpha-2 microglobulin, then you know that proteinuria is from post-renal origin and not from the kidney itself. You can also have overflow proteinuria, like for instance the light chains of immunoglobulins. If you find these in urine, it's not necessarily because there is a damage in the kidney function or in the glomerulus. They're very small. They will be shedded by the glomerulus even if it's intact. But if it's present in large amounts, then you can find it in urine, for instance in this lymphoproliferative disease. And of course, you can have a mixture of all these kinds of proteinuria. And this is what we measure to have an indication of the origin of the proteins. And these are some of the cases, for instance, in the case of postrenal proteinuria, we see that albumin, of course, is elevated, low molecular weight proteins, but you can also have the high molecular weight proteins. That's very specific for the postrenal origin. You won't find them almost never in all situations. For instance, if you have the glomerular proteinuria, then that's an early damage of the glomerulus. You will find albumin. You won't find much of low molecular weight proteins because they are still reabsorbed by the tubule. And also the high molecular weight proteins won't be present if the damage in the glomerulus is not too heavy. And this is typically for pre-renal proteinuria. Albumin is an indicator of the function and integrity of the glomerulus. It's normal, so the glomerulus is intact. You can find low molecular weight proteins, and these are originating from the serum, too high counts, and they're filtered by the glomerulus. They're overwhelming the tubule, and that cannot be absorbed these proteins enough, so you can find it back in the urine. These are just some examples, and this is the technique that we use, for instance, in the clinic. This is the everyday situation in which we have here 4 patients on this gel. It's an agarose-based gel. What you find here is the different fractions which are present in urine and also in serum. You can find here albumin at the first position, and then you have alpha 1 fraction, alpha 2, the beta, and here is the protein, the heavy weight proteins. What is done is that the sample of this patient is applicated on all these lanes. And every lane you have the electrophoretic power that is applied. You have the proteins are separated, and different immunological tolerance are used on every lane. For instance, this indicates tubular proteins. You can see that it's a very sensitive method. This, for instance, is the beta transferrin that you're measuring. Here you can see a bit of the alpha 1 microglobulin. Then in the second lane, it's for the detector of albumin and alpha 2 microglobulin. This is the albumin present, so you can see that there's glomerular damage in this patient. And then you have the heavy and light chains of the antibodies. Like for instance, this patient is not any protein measurable in urine. In this one there is, and this one is a larger glomerular damage because you have the heavyweight globulins present in the urine. And that's what we report to the clinician, who is then able to have an idea about the damage of the kidney, which measurements can be taken, which medications can be given to this patient. But the last one is something about the urine tract infection. That's also very important in routine daily practice of the lab. Typically, this is done by test strip and microscopy together. We also use in our lab specific proteins for detection of proteinuria, and sometimes also in the case of urinary tract infection. This is what you know and what you're familiar with, the classical microscopy with urine. This is not done anymore in most labs. It's either automated in the classical way of microscopy. Then you have something like this, in which you combine test strip reading, automated microscopy, and then you combine this information to have an interpretation of the sample. And that's reported to the clinician. For instance, this is what the software detects. This is the automated urine. These are some of the elements you can find. In these are all epithelial cells, so that's not that's something that's not good, not very good quality, because you have the lower urinary tract proteins present here, if the epithelial cells are present. You should not see these in correctly voided urine. These are some examples. You can see this automated microscopy. Okay, these are the advantages that an automated microscopy, that you still have images available. You can judge the morphology, and you have a combination with the test strip reader. but there's also a different technique available for routine clinical use, and that's the flow cytometry. You're familiar with that in research conditions, but it's also available for analysis of urine. That's a more dedicated one, so you can't choose your own antibodies, but it's dedicated for identification of the structures present in urine, and with combination of several parameters, several colorants and antibodies, you can have an idea about red blood cells and about any structure present in urine. The disadvantage is that here you don't have a microscopic image of for instance, the casts and the cells, but it's much faster. It requires less intervention of the operator, so that's easy to use. And certainly when we go a step forward and we combine this with the proteins measured, then you have a better idea of the localization of the urinary tract infection. So the UTI is urinary tract infection. And you can see what's classically indicated as hyaline casts or pathological casts, which are specific for urinary tract infections. You can see that this performance in this photo is not very good. But when you use, for instance, the specific proteins like alpha-1 microglobulin, or you use white blood cells and you combine this, then you have a very good cutoff of where the urinary tract infection is present. The philosophy is that alpha-1 microglobulin is a tubular protein. If you have a tubular damage, you can find the alpha-1 microglobulin in urine, and that's of course an emergency. In our hospital, we use it, for instance, for little children, in which they come in the emergency department, they have a fever. The classic thing you have to think about is the urinary tract infection. But it's important to know, is it still located in the bladder, or is it uprising to the kidney with a possible kidney damage? If it's the latest situation, then you have to hospitalize the patient and have IV and antibiotics. If it's still located in the bladder, you just give Paros antibiotics and you send the child home. And in that instance, we use alpha-1 microglobulin. If it's elevated and present in urine, then you have a tubular damage, and the kidney is in danger, and you hospitalize the patients. If it's not measurable, then you can send them home. That's how we use it in clinical practice. And you can see that it outperforms the classical detection of white blood cells on cars. Okay. Then one of the last studies we did was to investigate if the use of the flow cytometry data could be used to predict the results of the culture of urine. You know that when you have a bacteriological analysis, you inoculate the sample on plates. You have to wait 24 hours, incubate them at 37 degrees Celsius, and then you have an idea about what bacteria it is, and you can use it for further identification and for antibiotic sensitivity testing. We wanted to know if we could use this flow cytometry data, which are immediately available within 5 minutes after receipt of the sample in the lab, and we would like to know if it's usable to have an idea about the results of the 24-hour culture results. And these are data out of our hospital lab, so that's a clinical situation, routine with in and out patients, in every kind of situation. And what you see here is that when we use the bacteria count of the flow cytometer, that you can use it to predict, for instance, if a culture is positive or negative after 24 hours. This, if you use a cutoff of 29 bacteria per microliter, we can have a sensitivity and a specificity which are acceptable. If you have bacteria present above 29 per microliters, then we are almost certain to have a positive culture after 24 hours. So this means you give antibiotic, maybe in a broad sense, but you can start antibiotic because you know that there's a presence of bacteria. When you add white blood cells to that model, it's even more, it's better with overall sensitivity and overall area under the curve. You could use this flow cytometry also in another way. You could use it to predict the efficacy of antibiotics used. This is a situation in which a patient is administered to is seen in the hospital. Antibiotics are started because of a positive, or because there's a suspicion of urinary tract infection, and this is what is done with some of the, like for instance, the white blood cells, you could see how the evolution is of the white blood cells to predict if the antibiotics is, or if the bacteria are sensitive for the antibiotics used. This is what is meant with responder patients. These are the patients in which the antibiotic is correct, is attacking the bacteria, and they are responsive. The non-responders are the patients in which the antibiotic is not good correlated with the bacteria, and you should use another one. But the problem with the culture is, as I said, you inoculate it, you have to wait 24 hours and then another 24 hours to see if, which antibiotic can be used in this patient. When you use the flow cytometry and you compare a sample on time 0 and at time 24, you can see if there is a good diminishment in the white blood cells, then you are sure that the antibiotic you are using is correct and you can continue using it. If you don't see this, then you should switch from antibiotics. So you gain 1 day in applying your antibiotic therapy. So when you should correlate the evolution of the white blood cell concentration and of the bacteria concentration. Also the bacteria measurement in responder patients, you should see a very steep and very soon diminishment in bacteria. No, this is not that evident because it's always said in flow cytometry you don't measure the viable bacteria, but you measure all bacteria. You could say that when you administer antibiotics, your bacteria will die within 24 hours. They are still present, and they should be measured by flow cytometry. So this is somewhat unexpected. You would only expect a diminishment after 48 hours or 3 days. But even in these 24 hours, you can see that they cannot be measured anymore by flow cytometry if it's an effective antibiotic therapy. Okay, that's the most important things I wanted to say about using urine in the clinical lab. And this is just for your information. If there's any information you need about analysis of urine, these are the guidelines you can use. It's an old guideline that's very extended. It's more than 90 or 100 pages only about analysis of urine. And this is something about the CLSE standards you will be familiarized in your professional life, because this is the lab standards that are used for validating methods and things. They issue guidelines that should be used in clinical labs. These are the two most important guidelines of analysis. Okay, then we have a 5-minute break, and then Dr. Sven will give you some more information about the research we did on urine. Sorry. Yes. Sir.
On slide 13,